Welcome, everyone. This is Mo Al-Sumidai with the Clinical Trial Vanguard, and I am here at the Clinical Oversight Forum with Veeva at the Den Pla Aquarium here in Copenhagen. And I'm here with the pleasure of David Appel, who is the CSM team lead at UCB, and Waseem Awad, who is the Development Excellence Consulting Leader at Veeva. Pleasure to have you both here.
Thank you for having us.
Thank you for having us.
Yeah. So we're going to talk a bit about outsourcing today. And David, your presentation today specifically, it begins with like a personal story about leading complex global phase 3 study and experiencing the challenges of a fully outsourced model. Now, how did those experiences shape the way that you approached later operating models decisions at UCB?
Yeah, thank you for the question. It's a very good question. Mainly what we experienced in the past is that when you outsource studies as a sponsor completely, you lose some of the insight how the study is conducted. We experienced a vast time the issues that we could not see how well or how bad maybe the studies are performed. And to give us back this oversight capabilities, it was a strategic decision to go more into our internal CDMS system. That's about outsourced studies. At the same time, by the way, we built this also to a level. At the same time, when we implemented this approach, it was helping us also to develop our internal operating model, which is really added value for us because with this new CDMS solution in place, the support of Veeva, and we do great projects together with Veeva on this regards, we are able now to really engage our own clinical operation managers and site managers to work streamlined on our own in-house model.
And if I may, I believe the objective was also to establish some sort of flexibility or freedom to operate, whereby you wanted to become CRO agnostic. So in simple layman's terms, being able to work with pretty much any CRO, of course, let's say balancing elements like the right processes, the right people, the right platform. Is that a fair?
That's a fair summary, right? CRO agnostic is something we want to pursue and we want to see how far we can get on this journey.
So would you say that the R3 guidance is pushing towards more of a functional service provider model compared to a functional, fully outsourced model?
To some degree, yes, but you need to be careful to see what kind of model you want to implement. So there are these FSO models, the FSP models. They are also working more towards the needs of a sponsor. They are less completely outsourced, but R3, I completely agree with you, is going in the direction that you want to give the sponsor a concrete, continuous oversight in the studies. So going away from essential documents to essential records. Therefore, if you want to make the step further, which is now required by R3, you need to have a system backing this up, right? And this is what we want to do in the near future.
Mm-hmm. And when you think about deepening the relationships with study sites, what specific behaviors or practices did you find most effective? And are there any early assumptions that changed once you started doing this work?
Absolutely. For a good site relationship, the sponsor needs to add additional efforts. And by this, I mean, he needs to be more engaged with the site. And site engagement is a role we kind of blended into our normal in-house CRA role. This gives us the opportunity to be closer to the sites. And this is really important to understand that sites feel the difference, they see the difference, and we can dedicate this extra kind of operating model for studies where we see a higher need and an added value. Yeah.
So UCB has brought certain study management functions back in-house, which we were just talking about. So beyond the organizational diagram, like what were some of the underlying pressures or realities that made this shift necessary?
I think it comes back to our portfolio. So for some study types, especially when we focus on rare disease studies, it is crucial that you build a close relationship with those sites from the get-go, from the start, because there is just limited amount of sites doing this. You want to bond and have a strong relationship with those sites early on. And to enable this functions, it's really crucial to have a streamlined in-house operating model, which iHome is. And talking to the sites, getting their feedback, we are reassured that this is the right way to go.
I do remember, just to that point, the first time you and I talked about the iHome model, and indeed the sort of genesis of this all was the rare disease space, right? And the fact that a lot of the sites were dealing with very complex, demanding protocols. And as a result, you were almost left in a position where you had to prioritize that relationship for the sake of the study, right? So that is probably one pillar that I think was clear from the beginning. And then, of course, there's the element of making sure that, well, let's be blunt, sites and patients it's a competitive landscape, right? So that's also one sort of pillar that we also wanted to capture in the iHome model, if I'm
Thank
correct.
you. Yeah, you're summarizing this quite well. And the hearts of my team definitely go into this direction because we see added value for the entire company.
David, you described how UCB's iHome journey unfolded in as like a stepping stone phases, right? It's like 1.0, 1.5, and then the fully internalized model, and how each stage sort of surfaced like different frictions in the processes, roles, and the partnerships that you have. So looking back, which transition point was the hardest, and what made that specific shift so challenging?
So yeah, that's a good question. So I think the hardest step was transitioning from iHome 1.5, which is not an official name, but it was a hybrid model in between, to the last step, which is 2.0, where we streamline processes, SOPs, and the platform. Why was this the most challenging part? I think because we needed to write our new SAP landscape, which is now built as we speak. So we really developed this towards an in-house operating model. But at the same time, our team structure was changed, significantly changed. But this is the highest added value now, because now you're really streamlined on all levels: processes, platform, and people.
And I think one thing that maybe we tend to take for granted is, at least within UCB, there is this sort of internal belief, right, and dedication to exploring different models to find the best fit one, right? And I think that's pretty unique. I've only seen it in in spots around the industry. But that being said, you were not afraid to explore different models. You were not afraid to explore different, let's say, platforms, processes, people that would work, because ultimately you want the best trial to go well. You're thinking about the downstream impact of patients, right? So again, oversight is sometimes seen as potentially a negative thing or something as a challenge. But with the new regulation, you could almost see it as an opportunity to really build on what you have, optimize, and all for the betterment of patients, if I may say so.
Yeah, I agree on that. Just to add, maybe with the R3 guideline changes, we really think we are ahead of the curve.
Yeah.
Even that was not our first intention, but it's really matching now to what we
It
want
is.
to achieve and do.
And so for organizations considering similar changes, what's one insight you wish someone had told you before you started this initiative? And, something that would perhaps help others anticipate the human or the operational realities being, behind a model shift like this?
Yeah, that's a huge question. So definitely you always underestimate the complexity and the time you need to invest to make this kind of changes. But now, going in this evolution step-by-step process, we really appreciate that all stakeholders, internal and external stakeholders, we want to achieve the same outcome at the end. The way how we get there is via different operating models. And iHome is not the only model, as you said, Waseem. We strongly believe that a majority of studies will still be outsourced, but we want to make the outsourcing and the model more smarter, more adapted towards the needs of the future with R3.
If I may add to that, and I fully agree, the best piece of advice that I could, tell any other sponsor thinking of doing something similar is it is truly not binary, right? There is not one model that works for everyone. There isn't a single wrong or incorrect model either. You and I joke about this all the time, and we always quote George Box, the famous statistician, who says all models are wrong, but some are useful, which is indeed right. We cannot mimic reality. Some models will be wrong. But again, keep an open mind. Don't look at it as a binary equation. And at the end of the day, if you end up with 1 to 2 models that work the best for you, that's great as well.
And here's what's interesting, because we did the survey earlier, and about a third of the respondents said that they just want a full-on, out-of-the-box solution to implement R3. Is this even a possibility, or is this like a dream?
You want to take a stab at that?
Yeah, Casella, it's maybe a dream, and people should have dreams, but I think we are on the right path to make this dream come true. Yeah. I'm not sure if this will happen, but the journey is so early now that we'll see.
Anything is possible, right?
Absolutely.
Yeah.
Yeah.
But then each organization has to, what I'm learning from you is that each organization has to define its own structure, its own SOPs around R3. So, Waseem, do you think this is like a possibility where sponsors can just take an out-of-the-box solution and just implement it for R3?
To be blunt, no. I will say that there are certain technology stacks that, of course, help more than others. That being said, maybe we should look at it slightly differently. I don't think that there should be an out-of-the-box solution that you just plug and play, turn on a button, and then oversight works magically, right? I think the regulation is clear, but it's also set up in a way to allow for certain interpretation or actioning that is sponsor-specific. And probably that's where the added value comes in because, R3 can push a sponsor's organization to optimize how they work with their CROs. That is a plus, right? So long story short, out of the box plug and play, no. Is that necessarily the end of the world? Also no.
It's still a bit early,
Yeah.
but I think you're on the right path here. Every sponsor has to define their own QTLs, the KPIs,
Absolutely.
and the guidance itself has to, indicates that sponsors have to essentially demonstrate oversight. And in order to oversee something, you have to be able to manage it, be able to control it, and to give that fully away, how could you demonstrate oversight if you're just giving it to someone else? I mean,
Indeed.
it has to be involved, right?
And to be honest, oversight is not a novel concept, right? Most sponsors have been doing it for years, if not decades. It's very much the norm. What is changing now is obviously the type of oversight. So we're no longer looking at only documents. We're looking at documents, data, metadata, but maybe most crucially, the decision that leads up, or the pathway that leads up to the decisions, right? So a kind reminder to the audience and the folks at home, oversight is on you. It's not just that now we're going about it in a different way, if I may say so.
And my last question, and we did sort of touch on this, change management, and Waseem, you're mentioning people, process, collaboration changes. So given, David, the changes you implemented, what has been the biggest internal mindset shift required to make the new operating model truly work? And how did you help teams move forward with it? It's really tough to implement change in pharma. So I'm curious to know how you overcame that journey.
Yeah, we're still working on this. So definitely this is something we need maybe to improve internally too, but I believe that when people work already in the early adopter studies and see the added value of this new operating model, they will spread the word also across our stakeholders, but we need to formalize this more. And this is our new exercise for the next year to implement a more robust change management strategy.
I have to agree. I will also say, having worked with UCB and specifically David now for a couple of years across different projects, their ambition and also maybe their openness to experiment, of course, within guardrails. Conceptually, you can experiment, you can think about one model versus the other. I think that was very much, it's helped the organization get behind the idea because we showed them a bunch of different models. That started the curiosity from their side. And then bit by bit, you start to see, okay, this is actually practical. This could actually be done with the CRO. Let's take pieces of the model, even if we don't take the whole thing, right? So again, I need to applaud David and UCB for the openness to think beyond what is as is, right? And of course, their ambition to become CRO agnostic, to serve the patients better, truly is, something unique.
Yeah, thank you so much. And we appreciate also support from Veeva on this journey, as long as my cake.
Waseem Awad and David Appel, thank you both so much for joining us today.
Thank you so
Our
much.
pleasure. Thank you.
Thank you.